So good evening.
Hello, good evening. Hello.
Sir, good evening.
Yeah, can you hear me?
Yes, sir, I can hear you, sir.
Okay.
Hello.
Hello, good evening, Dr. Vivekanand here.
Good evening, sir. Dr. Shoaib here.
Yeah, nice to see you.
Please wait for the other people.
Yeah, we'll start by 8:15. I think.
Okay, sir.
Hello.
Yes, sir,
Hello.
good evening, sir. Yes, sir, good evening.
Good evening.
Hi. Good evening. I'm Dr. Dheeraj from Chikodi KL Hospital.
Yeah, nice to see you.
Hi, nice to see you, sir. Yes,
Dr.
sir.
Vivekanand.
Hi, sir. Hello, sir. So, have we started the meeting?
No, we'll start by 8:15. Wait for others to join.
ಒಬ್ರು ನನ್ನ ಪೆಸ್ಟಿಡ್ ಕ್ವಶನ್ ಒಬ್ರು ಚೇತನ್ ಅಂತ ಬರ್ತಾರೆ ಡೈರೆಕ್ಟ್ ಆಗಿ ಇಲ್ಲಿಗೆ ಕೆಲಸ ಅಲ್ಲಿ ಯಾರು ಹೋಗ್ತಾರ್ರಿ ಅಲ್ಲಿ ಯಾರು ಇರ್ತಾರ ಈ ನೈಟ್ ಅಲ್ಲಿ ಆ ಕತ್ಲಲ್ಲಿ ಯಾರು ಇರಲ್ಲ ಅಲ್ಲಿ ನೈಟ್ ಅಲ್ಲಿ
ಅದೇ ಗ್ಯಾಪ್ನಾಗ ಸೀದಾ ಅಲ್ಲಿ ಸೀದಾ
ಹೇಳು
ಅಲ್ಲಿ ವಾಸನೆ ಕೇಳಿದ್ರೆ
ಏನ
ಅಲ್ಲಿ ಒಳಗೆ ಹೋಗಿದ್ದೆ.
ಹೌದಾ
ಲಾಸ್ಟ್ ಟೈಮ್
ಎಲ್ಲ ನಾರ್ಮಲ್ ಇದ್ದೆ ಅಂತಲ್ಲ ಎಕೋ ಎಲ್ಲ ಮಾಡಿಸ್ಬಿಟ್ಟಿದ್ರಾ ಗಾಬರಿಗೆ ಎರಡೇ ನಿಮಿಷ ಅಮ್ಮ ಗೊತ್ತಿ ಗಾಬರಿ ಆಯ್ತಲ್ಲಮ್ಮ.
ಚೆನ್ನಾಗಿದ್ದಾರೆ.
ಇವರು ತಮ್ಮ ಅಲ್ಲ, ನಂಗೆ ಮತ್ತೆ ಹೊಡಿದ್ನಿ ಬರ್ತಾರ ಅಂತ ಇವ್ರಿದ್ದಾರೆ ಅಂತ. ಓಕೆ, ಹಾ.
ಅದು ಲಾಸ್ಟ್ ಟೈಮ್ 15 days ಬಿಟ್ಟು
ಓಕೆ, ನೋಡಿ
15 days ಬಿಟ್ಟು ಬರ್ರಿ ಅಂತ ಹೇಳಿದ್ರೆ
ಓಕೆ.
ನಾವು ಚೆನ್ನಾಗಾಯ್ತಲ್ಲ ಸೂಪ ಅಂತ ಹೇಳಿ
ಏನ್ ಕೊಟ್ಟಿದ್ರು ಅವ್ರು ಮಾತ್ರ? ನಾನೇನು ಹೇಳಿದ್ದವರಿಗೆ.
ಸರ್ ನೀವ್ ಹೇಳಿದ್ರು.
ಅದು ತಿಂಗಳು ಸ್ವಲ್ಪ ಕಡಿಮೆ ಆಗಿತ್ತು. ಮತ್ತೆ ಇವತ್ತು ಬೆಳಗ್ಗೆ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ.
ನೈಟ್ ಸ್ವಲ್ಪ ನಿದ್ದೆ ಬರಲ್ಲ ಅಂತ.
ಏ ನನ್ನ ಹತ್ರ ಬಂದ್ಬಿಟ್ಟು ಹೋಗಿಲ್ಲ ಮಾಡ್ಸ್ಕೊಳಕ್ ಫಾರಿನ್ ಹೋಗಿದ್ದಲ್ಲ, ದುಬೈ ಹೋಗಿದೆ.
ದುಬೈ ಸರ್ ಎಷ್ಟಿದೆ ಸರ್ ಅದು ನೀವು ಕ್ಯಾಪ್ಚರ್ ಮಾಡಿದ್ರಲ್ಲ ಸೆಲ್ಫಿನ?
ಅದು ಸಖತ್ ಟಾಲೆಸ್ಟ್ ಬಿಲ್ಡಿಂಗ್ ಅಲ್ಲ ಅದು.
ಹೌದಾ?
ಅದೆಷ್ಟು 900 ಮೀಟರ್ ಅಂತ ಸರ್, 886 ಮೀಟರ್. ಅದಷ್ಟು ಟಾಲೆಸ್ಟ್ ಬಿಲ್ಡಿಂಗ್ ಯಾವ್ದು ಇಲ್ಲ ಈಗ. ಅಂದ್ರೆ ಅಲ್ಲಿ ತನಕ ಕರ್ಕೊಂಡು ಹೋಗಲ್ಲ ಅವನು, 800 ಮೀಟರ್ ಕರ್ಕೊಂಡು ಹೋಗ್ತಾನೆ. ನೆಕ್ಸ್ಟ್ ಯಾವ್ದೋ 1 ಕಿಲೋಮೀಟರ್ ಯಾವ್ದೋ ಮಾಡ್ತೀರಂತ, ಅಲ್ಲೇ ಯಾವ್ದೋ 1 ಕಿಲೋಮೀಟರ್ ಬಿಲ್ಡಿಂಗ್ ಸಕ್ಕದಾಗಿದೆ. ಅವರ ಬಿಲ್ಡಿಂಗ್ ಮೇಲ್ ನೋಡಕ್ಕಿಂತ ಹೊರಗಡೆ ನೋಡೋದಕ್ಕೆ ಚೆನ್ನಾಗಿ ಕಾಣುತ್ತೆ. ಬಿಲ್ಡಿಂಗ್ ಹಾಗೆ ಅಂತ ಅನ್ಸ್ತಿಲ್ಲಪ್ಪ ನಂಗೆ ಫೀಲಿಂಗ್. ಇದಕ್ಕೆ ಇದು ಈಗ ಏನ್ ಕೊಟ್ಟಿದ್ದಾರೆ ಅದು? ಈಗ ಇಲ್ಲಿ ಚುಚ್ಚಿದಂಗ ಆಗತ್ತಮ್ಮ.
Good evening, Vivekanand sir. So, can we start the meeting, sir?
Yeah, sure.
Yes. So, good evening, one and all. I welcome you all for Strengthening Hearts Expert Summit meeting. So today we are with us Dr. Vivekanand Gajapati, MDDM cardiologist from Narayan Heart Care Center, SDM Hospital, Dharwad. Okay, so Dr. Session will be handed over to you, sir. So you can start.
Thank you. I would like to share my screen. Good evening, everyone. At the outset, I would like to thank CIPLA for this opportunity. Are you able to see my slides?
Yeah.
Yes, sir, it's visible, sir.
Yeah.
Yes.
So today I welcome you all to this expert panel meeting on mineralocorticoid receptor antagonists, both spironolactone and eplerenone. I welcome all our panelists. I will introduce one by one. So Dr. Ramesh Dodbangi is a physician at Vivekanand Hospital, Sankeshwara. And Dr. Dheeraj Paul is a physician at KL Hospital, Chikodi. Dr. Kiran V is a physician at NH Hospital, Shimoga. Dr. Viksha Jairam is a physician at Rajkumar Hospital, Shimoga. Dr. Shoaib Ahmad is a physician at K. Segade Hospital, Mangalore. And Dr. Uday Naik is a physician at AJ Hospital, Mangalore. Dr. Samarth is a physician at Samarth Clinic, Davangere. And Dr. Praveen Kumar Kusbi is a physician at Hubli. I welcome you all on behalf of CIPLA for this expert panel meeting. The main objective of this meeting is to gain insights on how do you place this mineralocorticoid receptor antagonists in patients with heart failure management. Because when you see heart failure management prescriptions, many of these patients will not be receiving these agents. And even though they are receiving, they will be receiving it at low dosage, and some of them will be continued even if the patient is having side effects like hyperkalemia. So many physicians, they don't use it with the fear of hyperkalemia. Is it a really concern in physician practice? And to create awareness among physicians on the role of mineralocorticoid receptor antagonists in the management of heart failure. So this slide shows overall global epidemiology of heart failure. It affects about 26 million people worldwide, and 1 to 2% of the adult population in developed countries. And its prevalence increases with age. And in India, 1% of the total population are affected. So almost we have 8 to 10 million patients with heart failure in India. And mortality is about 0.1 million individuals per year. So we know about the NIH classification of heart failure. But ACCH has 4 stages of heart failure. These are different from NYHA class. Stage A is patients who are at risk of heart failure, like patients with hypertension, diabetes, obesity. That is a pre-heart failure. Once they become symptomatic, then we see these patients and diagnose the heart failure. And stage B is advanced heart failure, where we need to admit these patients and they may require advanced heart failure therapies. So this is different from NYHA class. This is a symptomatic treatment which you all know. So there is another classification of heart failure by LV ejection fraction. It's very important from the treatment aspect of as well as prognostic aspect. So heart failure with ACCHA published its guidelines in 2022 after several modifications. So this is available in Journal of American College of Cardiology. So heart failure with reduced ejection fraction is EF less than 40%. And preserved ejection fraction is EF more than 50%. In between, we have mid-range ejection fraction, that is a 41 to 49%. And now they have introduced one more term as heart failure with improved ejection fraction. The persons where EF was less than 40% earlier, and now it has improved to more than 40%. So now I need to ask the Hello.
Hello.
Now I would like to ask our panelist, Dr. Dheeraj Paul from Chikodi, that according to his experience, what percentage of heart failure patients approach to you in NYH stage 2? And how many patients goes undiagnosed in India at an early stage?
Hi, sir. Good evening to all. Sir, actually, I'm an internist. I'm practicing at KG Hospital, Chikodi. Uh, if I consider all the heart failure patients which come to me, almost each and every patient will be in NIH grade 3 or 4.
Okay.
And a lot of people, lot of patients go undiagnosed in India at stage 1 and stage 2. A lot of things are there which attribute to it. First and foremost, the most important thing is ignorance of the symptoms. Patient will ignore the symptoms and they will attribute it to the workload or lot of work stress or something. Even if they have breathlessness, they will just take rest and they will say, "I'll work on kar liya, so let me take rest." They won't go to a doctor to consult to why he's breathless or why he's feeling uneasy. So that is the main cause where lot of the symptoms or a lot of the patients are undiagnosed on the early stage, in my grade 1 and grade 2. And the majority of the general GPs which are practicing in the periphery, they won't diagnose level 1 and 2 first and second stage. That's why they progress to the third and fourth stage, as I feel. And as per the diagnostic and prognostic tools used by me, so as soon as the patient comes to an ER or an OPD, we'll just take the history. Obviously, as we all know, they will be having either diabetes or hypertension or any known cardiac symptom, and it's just a lot of things will be there, as we all know. Okay. Other diagnostic test what we use is at the OPD level or at the ER level, general physical examination in JVP, pedal edema, murmurs, and cracks. Okay. The most common test what we do or at a taluka level hospital we do is ECG, 2D echo we see for the ejection fractions, we see the filling pressures, which guides the treatment, proper treatment for it. We get an early X-ray done to see the extent of the failure. If possible, then angiography if needed. We get the blood test which is for the renal failure factor, like we see for like sodium, creatinine, insulin, and if possible, like we see the BMP. Obviously, the prognosis will depend on the patient has low ejection fraction, when if there are any when arrhythmia or systolic blood pressure is very low, and if there is any associated renal failure. I think that should sum it up.
Thank you, Dr. Dheeraj. I completely agree with you. Most of the times we tend to diagnose this heart failure when the patient comes with the breathlessness and other symptoms of heart failure. And sometimes when echo is showing a reduced ejection fraction, when they write mild LV systolic dysfunction or moderate LV systolic dysfunction. But in in our usual practice, we tend to miss a lot of patients with heart failure with preserved ejection fraction when the ejection fraction is more than 50%. Like patient is having hypertension, left ventricular hypertrophy, and breathing breathing trouble. We tend to miss this heart failure with preserved ejection fraction. Especially these are common in the elderly people, and the incidence is almost same like heart failure with reduced ejection fraction. So now there are several biomarkers like BNP, NT-proBNP, troponin. So how common they use this biomarker in your routine practice, like BNP?
Sir, I at Taluka level. BNP test is not available in Korea, which we will just post it. So, a majority patients we treat on echo, ECG, and clinical features, also our routine blood test. Okay, BNP we do censor, but
yeah, these are
don't
quite
use
expensive investigations. So in our hospital, we use SOP profile, that machine. We do this panel for any patient coming with shortness of breath. We do CPKMB, troponin, D-dimer, BNP, all together within 15 minutes. So BNP ideally should be less than 100. Yeah. Ideally it should be less than 100. Any BNP levels more than 500 makes us to suspect heart failure. So it is especially useful when the patient comes with COPD with acute exacerbation. So where we are not able to differentiate between whether it is a respiratory cause or heart failure. It's a very useful investigation. So I think apart from this BNP, NT-proBNP, they are basically marker of myocardial stretch. So sometimes many of these chronic heart failure patients will be having high troponin levels. May not be MI, but it suggestive of myocardial damage. And there are several other myocardial biomarkers are there like ST2, galactin-2, which we are also not using. So these are all indicators of poor prognosis, especially in patients with advanced heart failure. And now coming to the overview of management of heart failure, we all know that to reduce mortality, we have only few drugs, only 4 drugs like AC inhibitors or ARNI, that is a sacubitril valsartan, beta blockers, mineralocorticoid receptor antagonists, and now newly introduced SGLT2 inhibitor diabetes, irrespective of the presence of diabetes. So for all patients, we need to give diuretics for symptom relief, and some patients may require control of heart rate in atrial fibrillation, digoxin, revascularization, biventricular pacing if LBB is there and QRS is prolonged. So overall, for all patients with ejection fraction less than 50% or less than 40%, these are the class 1 indications, like 4 pillars of heart failure therapy. So what is the role of MRA? How this MRAs come into picture in the treatment of heart failure? This was introduced in almost 20 years ago, when a Rails trial showed that spironolactone, when used in patients with heart failure, severely reduced ejection fraction, showed 30% reduction in mortality. That is the classical Rails trial, where they used this spironolactone along with AC inhibitors, and yet the main side effects of spironolactone is gynecomastia. So Eplerenone has got less gynecomastia, and it was also tried in post-MI patients in FSS trial, where it showed 15% risk reduction. And later on, in patients with mild heart failure with reduced ejection fraction, where it has shown 22% risk reduction. So these 3 landmark trials have been incorporated into guidelines. If you see the beneficial effects of these MRAs, they are very much cost effective. If you compare the cost and benefit ratio, so mineralocorticoids are the #1 drugs in heart failure. So if you see the mortality reduction of each of these agents, so if you use AC inhibitors, ARBs, they reduce mortality by 17% only. If you use ARNI over AC ARBs, another 16%. So yeah, ARNIs actually reduce mortality by about more than 30%. And beta blockers reduce mortality by 34%. And mineralocorticoid receptor antagonists reduce mortality by 30%. SGLT2 inhibitors by 17%. And see the number needed to treat mortality over a period of time. You need to treat only 9 patients to prevent 1 mortality over 2 years. And to prevent all-cause mortality, number needed to treat only 18. And so if you compare the number needed to treat with all other agents, it's very less. So, and they are moreover very cheap. So mineralocorticoid receptor antagonist must be used in all patients with congestive heart failure. So these are the classic 4 pillars of heart failure therapy. So when the patient is having EF of less than 40%, GFR is more than 30, then we have to use these agents: beta blockers, AC inhibitors or ARNI, spironolactone or eplerenone, and SGLT2 inhibitors. So if you see the guidelines, it is a class 1 indication. So both the 2 MRAs is recommended in patients with the heart failure with the reduced ejection fraction to reduce heart failure, hospitalization, and death. The class 1 indication. What about patients of 41% to 50% EF? Here also they are indicated, but it's a class 2B indication. Better to use these agents. So the same thing has been reflected in this new 2022 ECC heart failure guidelines. What do they say is that if the patient is having NYHA class 2 and class 4 symptoms, heart failure with reduced ejection fraction, we have to use these agents, spironolactone, eplerenone, provided GFR has to be more than 30 and potassium level should be less than 5. So they are contraindicated if you are not able to maintain potassium levels less than 5.5. better to avoid dangerous hyperkalemia. So this is the same thing. We need to exercise caution when using these agents because they can cause hyperkalemia. In one way, they're better because most of the loop diuretics which you use in heart failure, they cause hypokalemia. They counteract and maintain potassium levels, but sometimes they cause hyperkalemia. Now, I would like to ask Dr. Uday Nair, what is his opinion on monitoring of parameters like potassium levels, creatinine? Do you monitor these? Do you assess potassium levels and creatinine before starting the agents? And how often you repeat these tests?
Yeah, can you,
Spironolactone.
yeah, can you hear me?
Yeah, can go ahead.
Yeah. See, actually, these parameters, it is better to test. So we don't test routinely, but at least for some of the patients, at-risk patients, we always test for this serum potassium level, creatinine, and eGFR, and before initiating. And ideally, it is better to monitor this at least once in 3 to 6 months. Otherwise, if this patient's potassium level goes high, it may be a problem in some of these patients, especially for the
Definitely.
patients, it may be a problem. So at least in some of these patients, at-risk patients, we monitor it before starting the MRA, and at least once in 3 to 6 months we monitor.
Yeah.
And it is better to monitor in most of these patients.
Yeah, I totally agree with you. Usually, we will be starting other agents like AC inhibitors or ARB, ARNI also. So those agents are also contraindicated in patients with deranged renal functions. So better to get creatinine level, potassium, sodium levels when we start these agents and monitor. So I went through the guidelines which are published in 2022. So they suggest that we should check regular potassium levels and renal functions according to the clinical status. There is no hard and fast rule. Approximately after starting 1 week, you can check, and then after 4 weeks. Then, as you said, every 6 months, better to test these parameters based on the clinical stability of the patients. And Dr. Uday, in what percentage of patients you use these spironolactone or eplerenone in heart failure management?
Heart failure patients, I use around 20 to 30% of these patients.
Okay.
Around 20 to 30%, maybe around 26, 27%, I use this MRAs.
Okay. So they are strongly indicated in patients with heart failure with reduced ejection fraction less than 40%. Above 41 to 50%, we can use the class 2B indication. And even they can be used in patients with heart failure with preserved ejection fraction also, based on TopCat trial. So there are no strict guidelines that we have to use, but it can be used in patients with the heart failure with the preserved ejection fraction also. Thank you. And would like to ask Dr. Kiran that when do you consider starting MRA in the patients with the heart failure along with AC inhibitors or ARB and beta blockers? In other words, do you think this aldosterone receptor antagonist, these spironolactone, are they needed in patients with who are already on AC inhibitors or ARBs and beta blockers, which also reduce aldosterone levels?
Definitely. Hello.
Yeah. Please go ahead.
Yeah, definitely, sir. Definitely, since MRAs are class 1 indications, I think it's a very beautiful drug which has a reduction of almost 30%.
Yeah, exactly.
And especially I will use it if the potassium levels are less than 5. So to prevent from hyperkalemia, so I think I can definitely use the MRSA because it has a more added advantage to the reduction in the heart failures. So I use it if the ejection fraction is less than 35%, potassium is less than 5, and then with an good creatinine levels. Means less than, yeah.
Yeah, there is a rationale for using these agents, despite when you use AC inhibitors or ARBs. because there is a phenomenon called as aldosterone escape in congestive heart failure. So,
Yeah.
so when we use MRAs on the top of this one, better to use it before the discharge, because following an acute fall in aldosterone in response to administration of ACE inhibitors, these aldosterone levels rise again, and sometimes they return to baseline levels in almost all patients. That is called as aldosterone escape. So even when we give ACE inhibitors in combination with ARBs, aldosterone levels remain uncontrolled because there are several other mechanisms for formation of aldosterone. So they escape, they promote the release of angiotensin 2, which has got several deleterious effects. And this progressive escape of aldosterone is a cause of ACE inhibitor resistance. So there is a rationale of using these agents in addition to ACE inhibitors or ARBs. And when we compare spironolactone versus eplerenone, which one is better? But in our routine practice, eplerenone is expensive. So that's why we usually use spironolactone by default. Yeah, spironolactone by default in all patients. And only when the patient develops gynecomastia or other side effects, we tend to use eplerenone. But in a small study, which was published in Bangladesh, they found that these parameters of LV ejection fraction, improvement in LV diastolic dimension, systolic and systolic dimension, they found that eplerenone is better than spironolactone. There is a slight difference there. So this question goes to Dr. Ramesh. When do you prefer eplerenone versus spironolactone? Any specific reasons? I think if Dr. Ramesh is not there, Dr. Kiran, can you take up this question?
Sir, the thing is, one is about the cost factor.
Yeah, okay.
As in a city, in a country like India, the cost has a very important impact. Usually, I prefer spironolactone if the cost is one thing, and eplerenone I prefer if the patient is having gynecomastia, it is so awkward for him. So, and I think at that time, if the cost is not an issue, I'll go with an eplerenone. In routine, I usually use spironolactone as a patient profile. And in both cases, I'll always measure the potassium first so that we should not be in a condition to cause hyperkalemia. So I'll go with spironolactone first if the cost is a thing. And if gynecomastia has another added side effect, I'll go with an eplerenone.
Yeah, totally agree with you. This eplerenone has been used mostly in post-MI patients. So I've seen some physicians using eplerenone for patients with heart failure after post-MI patients. But since because of the cost constraints, it's better to use spironolactone in most of the patients and change it to eplerenone only when the patient develops side effects like gynecomastia and other things. So there is an algorithm how to manage this hyperkalemia, just the dosage. So most of the time we use spironolactone 25 mg OD, or if the patient is having slightly breathlessness, we use 50 mg if tolerated. Eplerenone, most of us use only 25 mg OD, but the ideal recommended dosage is 50 mg OD. Although it is expensive, we need to use 50 mg per day. Only when the GFR is less, use 25 mg per day. So when the potassium is less than 4, we can use this standard dosage like spironolactone 25 mg to start with, and then to increase 50 mg OD. And if the eplerenone, in case of eplerenone, we have to use 50 mg OD, and we can increase it to 100 mg OD. So I have not used this dosage. I used 50 mg up to 50 mg per day dosage. And when the potassium levels are between 4 to 5.4, literally no dose adjustments are required. Sometimes we have seen potassium goes more than 5, we tend to reduce the dosage. Up to 5.4 is acceptable. Usually I advise my patients to reduce curtail fruit intake so that this potassium doesn't get raised, especially in patients with a deranged renal function. But we have to be careful when the potassium goes more than 5.5. So if the patient is already on spironolactone, better to reduce the dose. If it is already on 25 mg, we can make it every alternate day. Similar in eplerenone also, we have to reduce the dose or decrease the frequency. But when the potassium levels are 6, we need to stop it absolutely. So the next question, if Dr. Praveen is there, he can answer. What is the preferred dose, and how is the dose titration carried out in your clinical practice?
Good evening, sir. The preferred dose usually depends upon the, for eplerenone, usually if the GFR is normal, that is more than 60, usually start with 50 milligram. And for spironolactone, usually we start with 25 milligram. So that is the preferred dose. But however, if the GFR is between 30 to 60, we come down by half. Down by half. So it depends upon the GFR and the potassium levels. So based on the potassium levels and the GFR, we will titrate the doses accordingly. So if the potassium crosses more than 5.5, then we need to come down on the dosages, or sometimes we can give it on an alternate days. If the GFR is not permitting us, or the potassium is high, we can go to a lower level. We can give it on an alternate days, small doses. So we need to be very careful when the GFR is. We should not start when the GFR is less than 30. So if the GFR is less than 30, usually we wait till the GFR improves to more than 30. Or if the absolute potassium is more than 5.5, then we need to be very careful. We need to recheck the potassium after a week or so to wait till the potassium becomes in the manageable level. So let it less than 5.5. Then we can start with the this MRAs.
Dr. Praveen, most of these patients of MI, post-MI with suppose say ejection fraction 40%. Usually we discharge them on EC inhibitors, beta blockers, and spironolactone 25 mg. Suppose if this patient develops hyperkalemia and want to stop spironolactone, can you hear me?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Suppose this spironolactone, if you have to stop this spironolactone,
yes,
do you use other loop diuretic like torsemide 5 mg or furosemide 20 mg? Because these patients are more prone for congestive heart failure. So one,
sir,
if
first we need to confirm whether that hyperkalemia is because of the MRAs itself. Only in 50% of the cases, it is attributed to the MRAs. In rest 50% of the cases, it may be because of some other reason.
Most of these patients will be on AC inhibitors also. AC inhibitors ARB. Right. They also contribute. They do
contribute. So we have to see that what is the main contributing factor. And but since the potassium levels cross more than 5.5, usually we tend to stop the diuretics, the MRAs for a week or so. Again, then reassess. And meantime, if the patient still has a lot of volume overload and features of congestion are there, we can start with the loop diuretics.
Yeah. There was a concern about hyperkalemia when we use both these AC inhibitors or ARBs plus spironolactone. But as you said, this in many trials, including real trials, also showed that this hyperkalemia is not a concern, major concern, because the overall incidence of hyperkalemia was 9%, and as you rightly said, almost 54% was truly related to MRA only. So it can be due to some other reasons like renal dysfunction or use of AC inhibitors. So if hyperkalemia is not a concern, we can use both AC inhibitors and AC inhibitors or ARBs plus spironolactone also. And Dr. Praveen, what percentage of heart failure patients on MRAs develop hyperkalemia? And in how many percentage of you try to discontinue in your clinical practice? Suppose you started spironolactone. In how many percent in your experience? Yeah.
So as per studies, they say it is around 10%, 9.3 to 10% they get hyperkalemia. But out of these, the total incidence of hyperkalemia, only half is attributable to these MRAs. Yeah. The rest half is because of some other cause for hyperkalemia, as AC inhibitors or some other issues may be there. So in these patients, we need to be careful.
Yeah, definitely. Thank you. This question is to Dr. Shoaib. So, what is your opinion about this hyperkalemia problem? How do you manage these patients?
So, good evening, sir. Thank you and welcome to all the panelists. Like I said, sir, we have already discussed here. Hyperkalemia is one of the main issues regarding MRAs, even though the drug is a beautiful drug. So I feel, like you said, even though it is 10%, most of the times there are multiple factors which are associated for the hyperkalemia. So I think it's also important that we tell them regarding the other things which can worsen hyperkalemia, like dietary things, certain fruits, avoiding fruits and juices, as well as certain other drugs which can worsen your hyperkalemia. Like you said, it is 10%, but a few studies have even shown that the actual percentage is 2 to 3%, where MRA alone is used. So I think it is important to stress on that also. And regarding the discontinuation, so like Dr. Praveen said, in case if it is above 5.5, I think we should stop it for a week, measure the potassium again, and in case if it is coming below that level, you can restart on the MRAs. As well as if it is more than 6, I think it's better to stop the drug and wait for some time. One more, I think, reason to discontinue might be when the eGFR is less than 30. Like you rightly said in the beginning, sir, potassium less than 5, eGFR less than 30, these drugs should be avoided. So I feel that is the way.
Yeah, thank you. And most of our patients of heart failure nowadays they are on sacubitril valsartan. And if you see the most important side effects of sacubitril valsartan is also hyperkalemia and renal dysfunction. But the good thing is that in there's landmark Paradigm HF trial, they found that the incidence of hyperkalemia is less in sacubitril valsartan as compared to enalapril. So still we use this Arni along with spironolactone.
Okay.
And the most important thing is that this timing of initiation of these MRAs are also important after a heart failure. In FSS study, where they used eplerenone in patients with post-MI LV dysfunction, they found that it is useful only when we start in patients earlier administration, that is within 3 to 7 days. It improved LV systolic dysfunction and heart failure in patients with post-MI. So better to start as early as possible post-MI. Otherwise, if you start it after 7 days or 8 days, patients won't get much benefit. And Dr. Shoaib, in your clinical practice, how early you initiate these MRAs, especially in patients with post-MI or other patients with dilated cardiomyopathy with heart failure? How early you start these MRAs?
Yes, sir. Like you rightly said, sir. Initially, when the patients come with a reduced ejection fraction, we stabilize them, and usually within 3 to 7 days, or ideally prior to discharge, we start them on MRAs, and usually tell them to follow up with the potassium after 1 week. And like these studies and few other studies have told, the earlier you start, better the effect is. So I think 3 to 7 days, ideally.
Yeah, it should be ideal because most of the patients with acute MI, they are prone for cardiogenic shock or congestive heart failure or renal dysfunction. So I think better to wait for 2 or 3 days. We can start these AC inhibitors as early as possible. Beta blockers usually start once the patient is decongested properly. We can use loop diuretics in the initial phase if the patient is having LV dysfunction and heart failure. Then we can introduce this spironolactone and even SGLT2 inhibitors also later on. Even in patients with a dilated cardiomyopathy with acute decongestive heart failure also, we use the same protocol. First we try to stabilize with the diuretics. Once the patient is symptom free, hemodynamically stable, we start AC inhibitors or ARBs or even ARNI also first. Then we introduce beta blockers, SGLT2 inhibitors, and even we can start this spironolactone also. So if you follow the old concept of escalating these medications, it will take 3 to 6 months. But now the newer concept is that we need not wait to escalate these medications for 6 months. We can try to introduce all these medications in patients with congestive heart failure, especially EF less than 40, within one month we can try to titrate all these medications, and thereby we can bring down their overall mortality. Thank you.
Thank you, sir.
So this is the routine algorithm for our patients of heart failure, especially patients with reduced ejection fraction. So this we have already discussed: the loop diuretics, spironolactone, SGLT2 inhibitors, beta blocker, AC inhibitors, and advanced treatment. I'm not going to the details of this. And these are next set of questions are to Dr. Samarth. At what stage of heart failure you use the diuretics and MRAs? Both you use.
Good evening, sir. Can you hear me?
Yeah, I can hear you.
Good evening, sir. As we already discussed, the MRAs are usually used in heart failure with reduced ejection fraction, sir. Even if the patient is having some amount of congestion, we can start initially with diuretics and later we can start with MRS. And in patients with the refractory cases, we can start both the tablets at the same time, both the treatment at the same time.
And what is your diuretic of choice in these patients, sir? Furosemide or torsemide?
Yes, sir. As we already discussed, sir, Eplerenone, one thing is a cost benefit. Spironolactone is cost effective, whereas Eplerenone, as it is costly, we can start with torsemide and Eplerenone.
Many of these combination available. This torsemide and Eplerenone combination. We don't have furosemide plus Eplerenone combinations.
Yes, sir. Torsemide and Eplerenone is the preferred drug of choice for these patients, sir.
Okay, I totally agree with you. And spironolactone, we have combinations of torsemide plus spironolactone or furosemide with spironolactone, which are cost effective. But torsemide plus eplerenone combination are also nowadays available, and we can use in suitable patients who require these MRAs. And now the last set of questions to all panel members. So according to your this one, what indications apart from heart failure where we can use this MRAs apart from heart failure?
We can use in ascites, refractory ascites.
Exactly. In fact, they use at a higher dose, like 100 mg.
Higher doses, yes, sir.
Yes, sir. Ascites. And we can use it in refractory hypertension also. In fact, yes, this is the drug of choice in refractory hypertension. When we have exhausted all the other drugs like calcium channel blockers, beta blockers, other diuretics, and even beta blockers also, AC inhibitors, we can use. And other newer indications are we can use in patients with anyway, this is a heart failure only, heart failure with preserved ejection fraction also, we can use it. Any other indications? So in our clinical practice, we use mainly in heart failure and refractory hypertension and ascites. These are the most common indications for these agents. And last question, which is not an academic question. What scientific initiatives would you like to suggest to CIPLA for increasing awareness among clinical practitioners regarding the use of MRAs in general?
Question is for all?
Yeah. Anybody can.
Obviously, we can have some more sessions like this, and so that we all people from different parts of the state or country, we can share our views. We can update our knowledge from the specialists like you, sir. And obviously, we can have some more sessions in person in a district or something, as they are already doing.
Yeah, I totally agree with you. Because many of these heart failure patients, they are not managed according to the guidelines. So everybody has their own way of practice. Yeah, some patients will be on AC inhibitors, and many patients will be on ARNI, and many patients they don't receive SGLT2 inhibitors or even beta blockers, which are proven. So we need to standardize this treatment for all heart failure patients. The practice should be uniform. So if we definitely follow these guidelines, then definitely all our patients will be receiving standard treatment like beta blockers, EC inhibitors or ARBs, and this spironolactone according to the guidelines. So basically, we need to create awareness among our clinical practices, including GPs also, who also see these patients with heart failure. So if there are no more questions, then we can conclude the session, and I will hand it over to Sipati. Thank you for your active participation.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you so much, sir, and delegates and moderators. Thank you so much for discussion.
Hello, sorry, sir. Maybe network issue. This is Naveen Kumar from Cipla. Sir, thank you, sir. Thank you very much for your valuable time and discussions. Thank you so much. In coming days also, sir, we'll plan like this meetings. We'll plan, if possible, we'll plan a physical meeting only, sir. Thank you, one and all, for your valuable time and discussion. Thank you so much.
Thank you. Good night.
Yes, sir.
Good night. Thank you.
Thank you.